For the patient that is initially diagnosed and has hormone-sensitive breast cancer, most of those patients have early disease, early stage disease that is, and whether they get chemotherapy or not, they will receive a recommendation for anti-hormonal therapy. If they're premenopausal, the treatment of choice is tamoxifen. If they're postmenopausal, we would tend to start with an aromatase inhibitor, of which there are 3, and any of the 3 would be acceptable. One is not better than the other. If a patient then goes on to develop recurrent metastatic breast cancer, our decision about what the first step should be will depend on, are they still postmenopausal or premenopausal, and also the extent of the disease. So, for instance, if a patient has rapidly progressing bulky visceral disease, that may be a better candidate for chemotherapy. If they remain hormone receptor positive, because usually at first recurrence we would biopsy them to make sure that the markers remain the same. And if they are, then they would be a candidate for endocrine therapy. If their disease recently progressed after having received an aromatase inhibitor or recently progressed after receiving tamoxifen, we would certainly not revisit those drugs as a first choice. We would choose something else. So if a woman had tamoxifen, we'd give them an aromatase inhibitor. If they had gotten an aromatase inhibitor in the adjuvant setting, we might choose tamoxifen, or we might choose fulvestrant. And we would continue those drugs, whichever one was chosen, for as long as the disease appeared stable. And if there came a time point where the disease was progressing, again, we would go through the same decision tree and decide, does this patient need chemo or not? And if they did not, then we would consider alternative endocrine therapies, which again, we would sort of take into consideration what had that tumor been exposed to in the past and what available agents remain. And, of course, we always think about clinical trials. Might there be a clinical trial the patient's eligible for? If not, then we would also consider an aromatase inhibitor plus an mTOR inhibitor. And that's a recent strategy that's utilized for patients who've shown disease progression after having received an aromatase inhibitor. And that's based on the BLAIRO-2 trial. So in patients who develop disease progression, remain endocrine sensitive, we would consider adding everolimus plus, say, exemestane, and we would continue that therapy, again, until there's evidence of disease progression. At that point, patients may have received most of the endocrine therapies available, and if so, then we would have to start thinking about chemotherapy.